Hello, I'm Joel Stoddard. I'm an assistant professor at the University of Colorado School of Medicine, Department of Psychiatry, and an outpatient psychiatrist at the Pediatric Mental Health Institute in Children's Colorado. Today I'd like to talk about an important topic for pediatric health, specifically disruptive mood. Disruptive mood is a very common issue in pediatrics. Severe disruptive mood afflicts about 1 to 3% of children. It's the number one reason for psychiatric emergency visits. When kids are afflicted with intense disruptive mood, it can be very distressing and impairing. Family systems can have tremendous difficulty with it. Parents distressed, of course, calling the office, wondering what it is and how we can help. Disruptive mood has had a long history of different kinds of treatment approaches and maybe a little bit of mislabeling. Many experienced providers might remember disruptive mood being called pediatric bipolar disorder, or prior to that, perhaps, hyperkinetic disorder of childhood. Overall, though, folks have tended to focus on disruptive mood as just the behavior. In this particular slide here, I like to show a child who seems forlorn, depressed, and isolated, because even if we focus on the behavior, the main issue that's going on is an emotional disturbance in the child. We know now that disruptive mood, which is defined largely as sadness, anger, and temper outbursts, confers significant risk in adulthood. 30 years out, for example, it can predict a person's tendency to be suicidal. It predicts anxiety and depression. Notice here, I didn't say bipolar disorder. Severe irritability in children does not go on to predict bipolar disorder unless it occurs in discrete episodes, and that had been an important concern for providers. Finally, it predicts lower socioeconomic status and disruptions in adult relationships. So there's been a lot of research to try to unpack what's going on in kids' heads that leads to or perpetuates disruptive mood. Here is a basic schematic representing a bunch of different kinds of theories. There's some fancy words on this slide, but I'd like to just kind of break it down to two major concepts. The two boxes on the bottom, called encoding cues and interpreting cues, are about very early perception. Kids with disruptive mood tend to pay more attention to threatening cues or social signals of threat in the environment, and they also tend to interpret ambiguous or benign cues as threatening. For example, if a child with disruptive mood were to see the picture of the Mona Lisa, that child might interpret her as having a threatening or neutral face, whereas a kid without problems with disruptive mood might be more likely to see the smile. On the top half of the circle, we've got more regulation processes. These are clarifying goals and response selection. I put Rodin's thinker there because this is the part of the brain that takes in all of that perceptual information, integrates it, and helps drive positive behavior. That's why you need to know what goals you're having and hold those in mind, and have a good repertoire of responding. Kids with disruptive mood might have actually very limited understanding of what's the best goal for them in the moment, problems with impulsivity, and as well as a limited set of responses to choose from. In any case, if the child chooses aggression, that would prompt an in-kind response from someone else and perpetuate the cycle of negative mood and negative behavior. This slide also kind of gives us a schematic of important avenues for developing new treatments. Many people might be familiar with treatments that help children with clarifying their goals and response selection. These treatments typically are under parent management training, reward charts, but some kids need help with perceiving things, very early processes that might bias these later processes. And that's exactly what we're doing here in my lab at Children's Hospital, Colorado. So before I came to Children's, I was working with a group at the National Institutes of Mental Health, and we were able to map out where in the brain these processes are occurring. And you can see in this picture of this child looking at an angry face that there is a disruption in the communication between those areas for kids with higher irritability and higher anxiety. Both irritability and anxiety are the kinds of moods that can drive disruptive behavior. And in that fancy color graphic there, you can see something called the RE, and as the RE gets larger, you can see that the square patch gets bluer. That means the disruption between the emotional centers in the brain, the amygdala, and the controlling centers, higher order, the prefrontal cortex, PFC in the graphic, are becoming less well connected. There's disruptions in their communication. And on the other axis, you can see the scared. The scared is a common measure of anxiety. Many pediatricians use it in their office. And you can see that without irritability, very low RE, kids who tend to be just anxious only have a bit higher communication between these two regions. That doesn't necessarily mean it's protective. Maybe there's too much communication going on, and these kids miss out on important social opportunities. This early data shows us that there's a brain basis for these kinds of disruptive moods that can lead to these disruptive behaviors. And it directly relates to that cycle of cognition I was telling you about earlier. Of course, all this means is that we now have a pretty clear target of where we might start treatment trials. And that's exactly what we're doing at Children's Colorado. I'm just going to give you an example of one kind of trial. And this has to do with that very early encoding set of cognitive processes I was talking about a little earlier. What you're seeing before you is a schematic of interpretation bias training. What we do is we show kids pictures of different kinds of facial affect. And we go from extremely happy affects to extremely angry affects. Most people don't have trouble, even kids with profound disruptive mood, labeling overt emotions. However, when those facial emotions become kind of ambiguous, it's really hard to tell. That's where maybe there's a bias for labeling that ambiguous emotion as hostile. And again, like I said, if you think something is threatening, you might behave as if it is, even if it's not. Oh, think of the common adage, somebody walking around with a chip on their shoulder. So that's exactly what this kind of training targets, and the trial that we have going on in our lab. What we do is we first measure where a kid's interpretation bias is along an emotional continuum. We call that the balance point. Then we provide feedback to the child where we try to shift their judgments of these emotions towards more positive judgments. Whether or not this training is effective is a part of our ongoing treatment studies. We just finished a large trial and are looking at the results now. Even if the particular trial doesn't work, what we will learn is how this training affects brain mechanisms, and it will give us new insights onto new kinds of treatments. For example, this is a computer-based treatment, so it can really complicate our repertoire of medications and psychotherapy. So, in this short presentation, I gave you a little bit of overview on disruptive mood. What's really important is in the past 10 years, we've learned that disruptive mood is generally the result of negative emotions that kids experience. And we should not attend to disruptive mood as if it is just a problem behavior. That doesn't necessarily help get to the root cause. We've also learned that chronic irritability and severe disruptive mood does not necessarily predict bipolar disorder in adulthood. We might watch for children with severe irritability for their development of later suicidality or major depression or severe anxiety disorders. And then finally, I just kind of highlighted how cognitive processes and emotional processes might interact to perpetuate disruptive mood, and what kind of novel trainings that we can create from this to try to intervene. I hope you enjoyed our presentation on disruptive mood in children and found it informative or maybe given you new ideas about it. Thank you for your time.